Thank you so much, Abt. And on behalf of Obesity Canada, we're just delighted to be here, and thanks to Novo Nordisk for supporting this event. Can everyone see my slides okay? I think, yeah, thumbs up. So the three of us are going to be presenting today, as Ab mentioned, on the new 2020 Canadian Obesity Clinical Practice Guidelines. And I'm going to be providing a bit of an overview, and then Sarah is going to be diving in more to the issues related to weight bias and stigma. And Sean, who is our co-chair of the guideline committee, is going to then expand onto some of the science elements of obesity and further discussion around the treatment recommendations in the guidelines. So I just want to take care of a couple of items just in terms of disclosures. I don't personally have any financial relationships, with the exception of being on an advisory board for Pfizer around patient journey. And I have some research funding from the Canadian Institutes of Health Research and a competitive competition called NOVAD, which was jointly funded by University Hospital Foundation, Novo Nordisk, and the Government of Alberta. And then I am employed by the University of Alberta, so that is also an important disclosure. The program, the slides, etc., have all received significant in-kind support from our colleagues at Obesity Canada. I have not received any payment for participation in the guidelines or in participation in this webinar. And this is just an ASO statement for all of us that are speaking today, that Novo Nordisk has provided some sponsorship for ASO for this webinar. However, we have not received any reimbursement for participation in this event. I also would like to do a territorial acknowledgement that I acknowledge that we are on the traditional territories in Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So our objectives for the presentation today are fourfold. First of all, I wanted to provide a little bit of a background as to why we undertook the challenge of these 2020 Canadian adult obesity guidelines, review a bit about the process of the development of the guidelines, and then review the patient arc, which we had front and center in the creation of the guidelines and which informed their scope, as well as review some of how you can navigate the guidelines. And then finally speak briefly about the impact so far, the implications of the guidelines, and how we're trying to support their implementation. So going back to the why, so there's a significant challenge in Canada in terms of lack of understanding of obesity as a chronic disease, lack of clarity about definition of obesity, and significant issues with weight bias and stigma, as well as active discrimination against people living with obesity. And all of this results in a healthcare environment that has reduced screening and diagnosis and very little intervention. This leads then, of course, naturally to disease progression, as would be the case for any chronic disease. And it just reinforces a negative set of environmental factors that perpetuate the stigma and health inequalities that are related to that. And this is in a milieu of increasing prevalence of obesity in Canada. So it was really felt that there was a need to help change the conversation and to provide some of the enormous amount of evidence that has come to the field to put it more front and center for practitioners. And so at the time of the last clinical obesity guidelines in 2007, there's actually been an explosion of information as well as a real change in landscape. And so this was the backdrop under which we undertook these guidelines. So first of all, obesity was declared a chronic disease by the Canadian Medical Association in 2015. Reflecting increased understanding of the pathophysiology of this condition. And this then necessitates that it be treated as a chronic disease. But yet we see this impact of the bias, stigma, and discrimination on hindering that process. And so there was also a need to mobilize all the advances we've had in science, understanding of weight regulation, as well as advancements in treatments and therapies. And then that we actually have to have a broader impact on outcomes beyond just weight alone. So that's the background. So how did we undertake this? So the first of all was a clear mission statement. And this was what we set out to do collectively, which was to develop a non-biased, scientifically valid and trustworthy set of clinical practice guidelines with specific recommendations on the management of obesity to inform clinical decision-making that's patient-centered and to support shared decision-making in order to optimize patient care in primary care. And I want to emphasize that. So we recognize in our endeavor that the preponderance of this problem and the prevalence of this problem requires, in our context, that we have substantial effort in the primary care space towards addressing it. And that means we have to have a bit of a sea change to make sure that providers have the skills, attitudes, and beliefs that are going to allow them to be able to do this successfully. So from a methodological perspective, Obesity Canada, together with the Canadian Association of Bariatric Physicians and Surgeons, decided that this was a necessary step, and they assembled the executive committee, and it was co-chaired by Dr. David Lau and Dr. Sean Wharton, who's with us today. It was my great pleasure to serve on the executive committee and the steering committee with broad expertise in the topic and Canadian geographic representation. And it was broad engagement of a number of different stakeholder groups in the guideline process, which I'm going to expand upon in a moment. In terms of funding, we were very grateful to the Canadian Institutes of Health Research for providing support for these guidelines, in addition to the crucial funding from Obesity Canada and CAPS, as well as the staff at Obesity Canada, without whom none of this would have happened. And so this was the general structure. The other element here was the definition. So we early on realized that we wanted to make sure that these guidelines were grounded in current evidence. And we define obesity as a prevalent, complex, progressive, and relapsing chronic disease, which is characterized by abnormal or excessive body fat or adiposity that impairs health. So the recommendations in this guidance are for people living with obesity. They may not be appropriate or applicable to people who just happen to have larger bodies, who do not have health impacts from their weight. In terms of mitigating conflicts of interest, we had a very formal process for handling this, as is summarized on this slide, as well as in the guidelines themselves, and I'll speak about MRST just in a moment. So MRST, out of McMaster University, is the McMaster Evidence Review and Synthesis Team, and they are arm's length from the committee. They are methodologists, and they provided methodologic oversight and support for all aspects of the guidelines, from literature search. We use their distiller platform to handle the hundreds of thousands of articles that came up in the search, and use their infrastructure for handling the assignments for how to handle the critical appraisal, how to assign the evidence grades. And they reviewed all of the recommendations to ensure fidelity with the evidence. This graphic overlays the general timeline and flow, and this was an enormous amount of work and undertaking from this volunteer group. So at the beginning, the Memorandum of Understanding between Obesity Canada and CAPS outlined the roles and responsibilities in the timeline. We then had to define the scope and with the executive committee, and we undertook an interesting mind mapping exercise at that time to flesh out all of the things that we thought would be really important for people living with obesity and practitioners and family members to understand what the scope would be of these adult guidelines. Excitingly, the pediatric guidelines are now underway. So these guidelines apply to adults over 18. We identified members for the steering committee, invited authors, and applied for funding. Coming out of the mind mapping exercise and the scoping exercise, we then had each of the chapter committees work on finalizing research questions and refining them to be able to be searched and compiled through MRST. We deliberately recognized that a number of questions, as what Sarah's going to speak about with weight bias and stigma, those questions of importance to people living with obesity are in the realm of qualitative research. So we deliberately included qualitative and mixed method evidence to address questions of importance where that's the best form of evidence to find solutions, which is not something that we've seen a lot in other guidelines. We then went through the evidence review and critical appraisal by the authors, and then MRST helped with supporting assigning of grades on the results of those critical appraisals. We then had an iterative process to refine recommendations, which involved contextualization with people with lived experience and members of Indigenous communities, finalized with the executive committee and MRST. We then compiled the guideline manuscript and chapters, arranged for formal peer review of the main guideline through CMAJ, the Canadian Medical Association Journal, and external peer review of the chapters coordinated by Obesity Canada. And then we don't want it to be an expensive doorstop. So we want this to be used. So there's a deliberate implementation strategy for these guidelines. I want to give a nod briefly to the chapter on obesity with Indigenous communities, because it's extremely interesting to read. The recommendations are incredibly important, I believe. And the methodology that was used was also very important. And it really embraces the United Nations Declaration on the Rights of Indigenous People that states that health programs and policies should be developed with active involvement of Indigenous people. And so there was a detailed knowledge contextualization process in this guideline process, where a group of people from across the country were engaged to review all of the relevant scholarship within the framework of community expertise and with insights from healthcare providers who work closely as well with Indigenous patients. So this is the focus group where they had the conventional searching, identification of records, but then also passing that through this focus group process where all of these things were discussed and contextualized. And they used a specific structure for how they did the synthesis of the evidence, where they structured the findings according to insights for the Educating for Equity Care framework, which is an educational approach designed to enhance primary care delivery for Indigenous patients with diabetes. So this was the framework that was used, and it was really recognizing the core element of colonization as being a predominant cause of health inequality for Indigenous people, that healthcare equity is providing appropriate resources according to needs and addressing differential treatment arising from system and individual factors, empowerment, which is building capacity with patients to address social determinants influencing health outcomes, and respecting diversity of perspectives and experiences, with culture being a facilitator of clinical relationships and patient capacity. So again, people with lived experience in our public engagement committee, as well as patient representation on the steering committee, was present throughout the guideline process. People living with obesity, Indigenous community members, as mentioned, refined and looked at research questions as well as recommendations. So that was very important. The other thing I want to note is just the number of different kinds of chapters that came out in these guidelines as a result of that original mind mapping exercise, some of which are really meaningful for people living with obesity. The first one on enabling participation in activities of daily living for people living with obesity by Dr. Mary Forehand and colleagues, for example, really gets into the occupational therapy elements of this condition. And you can see here a list of some of the other chapters which weren't present in previous iterations of the guidelines. The other thing I want to mention is these are living guidelines, so they're not intended to be static. They're intended to react to new evidence as it becomes available. So now that the heavy lifting is done, hopefully they'll continue to be a living document. In Appendix 2 of the Canadian Medical Association Journal article, you'll find this 5A's framework for obesity management in adults. So the guideline is organized around the patient arc. And it really starts with this fundamental question of asking permission to discuss weight. And there's an entire chapter on assessment, which gets into some of these elements. Then assessing. So assessing is really around integrating evidence with the individual story and life context, and coming up with value-based goals that matter to people to help support them in active behavior change, as well as the conventional classification, and really understanding of root causes, which we'll expand upon just in a moment. There are emerging different scales that are coming out that address elements around disease severity, such as the Edmonton Obesity Staging Scale. There are others, but this is an area as well that's really important because we really wanted to try to move away from just a paradigm of weight as being the only outcome. We don't believe that that is the case. It's around how to help people be healthy as well. So again, moving on in the patient arc, we have advice. And one of the things that was incredibly important was we recommend that nutrition and physical activity recommendations are responsible for everyone, irrespective of body size or composition. So we have a shift in these guidelines to medical nutrition therapy, which is focused on chronic disease management, and really focused on personalizing to individual needs, values, and preferences and goals. And ideally, if possible, to be done in collaboration with a dietitian, which again is a system change issue in Canada because not everyone has access to that service. And again, recommendations around physical activity are core, but then there's the three pillars of obesity management that support these things. And you'll notice that there's bi-directional arrows. So this is not sequential, it's different pillars as it responds to the needs of individual people around the areas of psychological intervention, pharmacologic therapy, and bariatric surgery. And Sean's going to dive some more into some of these in his presentation. And then finally, we have the agree and assist. And of course, this is a chronic disease. So we're recommending chronic disease management, which means ongoing longitudinal relationships over time for the course of the person's life to help them with their illness. Just briefly, this is the 4M. So getting into the notion that root cause assessment and understanding what's driving a person to be having problems with obesity requires addressing the thing that's at root cause. So if the person has had sexual trauma, perhaps as a young person, you know, the treatment may be related to trauma-focused counseling, and that may be directly relevant to the treatment of their obesity. So it's taking a really holistic approach. In terms of the Edmonton Obesity Staging Scale, we're really coming back to this paper in Canadian Medical Association journal by Raj Padwal and colleagues, which demonstrated that BMI does not predict outcome in terms of mortality, but Edmonton Obesity Staging Scale does. And so that is sort of the frame that we're using in these guidelines to help clinicians begin to stratify and intensify therapy appropriately, depending on the level of illness that a person may have. In terms of resources, if you go to the Obesity Canada webpage guidelines, you'll find this landing page. We have been doing a number of things, which I'm going to outline in a couple of slides around outreach, which you can see here with the webinar series, as well as the OC Connect Pro on the right side. And you'll see some of the frameworks as well as links to the full chapters. The Timed Right group is very exciting. That's a dynamic community of providers that all of you are welcome to join, where there's ongoing discussions and questions and dialogue, because we know that integrating new practice into someone's practice leads to a lot of questions. And so that's a place where people can come together as a community to find answers. And then if you look at the guideline tab, you'll see all of the different chapters, which you can download the full PDFs of the chapters from these links. In terms of impact, we've been really delighted and overwhelmed in the middle of a global pandemic that this has had as much attention as it's had. By the end of August, we had over 81 million media impressions, which was just extraordinary. And you can see here some of them, that have come up, and it's continuing to have a high level of interest internationally. And certainly Sean would be able to speak about that. So again, this is just a summary of the dissemination and implementation with the original paper on the right, which is downloadable as well, or accessible as well from this link on the landing page. The ongoing efforts around dissemination are linking with a number of different webinar series like this one at ASO. There's a number of them happening in Canada, a number of activities happening through Obesity Canada, the Dietitians of Canada, so a lot of interest. Additionally, this is going to support and is supporting ongoing training. So there's courses and things for practitioners to be able to get engaged with to help them advance their skills. So I'm going to end here and turn it over to Sarah.